webinar. It's going to be very exciting, and the meeting is being recorded, as you may have just heard on the line. I'd like to welcome all of you and our colleagues who are giving this presentation from MyHealth Access today on screening for social determinants of health through a mobile text messaging mechanism. So with that, I'd like to just start by introducing our presenter. Jennifer Faries is the program manager of the Accountable Health Community Project, overseeing all of the day-to-day operations of that program for MyHealth Access. She has experience in the areas of program management, corporate development, finance, and direct mental health practice. She has a master's degree in both business administration and clinical psychology, and a remarkable background where she's worked in industry, as well as a mental health clinic and early childhood consultation program. She joined MyHealth Access in 2018 and has been providing training and support to clinical and community partners and has been the lead for the implementation of this exciting project. Also with us is David Kendrick, who many of you know, who is the CEO of MyHealth Access. David is chairs the Department of Medical Informatics at the University of Oklahoma School of Community Medicine, and he has been a tremendous force for the good in terms of creating information technology that really walks the walk and talks as well as talks the talk through MyHealth Access and working with the Office of the National Coordinator for Health IT. So with that, I'd like to turn it over to David just for a quick introduction, and then Jennifer will be sharing information about this very exciting program. Sounds like we may have lost David.
I was talking to my mute. Lisa, thank you very much. I will, both you and Jennifer have said to me, do a quick introduction, so I'll take my cue from that. Clearly you guys have seen me talk before too much. And so what I would say about this project in particular, this is a program funded by the Accountable Health Communities project that CMMI is working on. And Jennifer will give you a lot of more details about that. But the award happened in 2017, meaning the applications were in 2016. At that point, social needs were obviously well recognized by primary care providers as one of the big drivers of success in turning around patients' health and family health, and we're not really getting addressed. And so this demonstration project looked like the ideal fit for what we've been trying to do at MyHealth. As you know, MyHealth is a health information exchange at its initial foundation. Now we do a lot more analytics and so on. And this program represented for us the next natural fit. In fact, the community came to MyHealth after looking at the award. Maybe 25 or 30 different organizations were considering themselves for application to the organization, and realized that only one in a geographic region could apply and get it. And so we knew of the project, but we didn't make any moves that direction until the community actually came to MyHealth and said, would you apply and be our bridging organization? And so that, for me, was itself a good litmus test to our role in the community in determining whether we had any success there or not. And so we put the proposal in to be what's called the bridge organization between the various providers of healthcare in the community that we're going to be tasked with screening for social needs under this project. And we proposed a mechanism for doing these social needs screenings. Namely, our intention was to create new vital signs around the social needs and track those vital signs, because we already have that data flowing into the Health Information Exchange and can do reporting and alerting based on it. Unfortunately, Medicare had different ideas, and they provided their own survey once this was awarded, and their own software tool for tracking the results in. And so it complicated things a bit. And we spent almost a year trying to figure out how in the world could we take a long survey that takes about 12 minutes in a clinical encounter to complete with a patient, and get even a single clinic or emergency room to do it. And we didn't have any takers. So we had to come up with a new mechanism. And as you know, necessity is the mother of invention. And so as we approached the go live date, we had to come up with a new way of doing the screening, and we realized that we had a unique asset as the Health Information Exchange. We had the messages triggered upon registration, so we knew in MyHealth within about a minute of every patient registering for care, and we also know that patient's phone number. So by having that number and knowing that a significant percentage of those numbers were actually mobile numbers, we were able to kick off a workflow that Jennifer's going to tell you all about. And I would just say that everything that Lisa mentioned about Jennifer is true and more. She's been a fantastic driving force for this program. And I'm going to go on mute and let you take it away, Jennifer.
Thank you so much, Dr. Kinnick and Lisa. I really appreciate it. I'm really looking forward to sharing the details with you guys today. And I'm going to try to leave plenty of time at the end for you all to ask questions. I do have the chat function up, so if you have questions as I'm going through, I'll try to keep an eye on that and answer any questions that come along. I love to be able to hear what your feedback is and hear where you have questions, because sometimes that helps me identify what I didn't cover. So feel free to ask questions. So I'm going to start just by giving you a little background. Dr. Kinnick shared a lot of this, but MyHealth is the Health Information Exchange. It has a unique position in our community to be able to do this work. And one thing that we didn't talk about is that this project is funded by CMS, but it's being done by 30 groups around the country. And so it's a really interesting look at how this work can be done, because we're all using the same screening tool. We all have some of the same requirements for milestones, but we're all delivering it or deploying it in a little bit of a different way. So today my goal is to just share with you how we're deploying this and how we think this is a really great way to start to screen people and meet their social determinants of health needs at scale. So I think Dr. Kinnick covered, many slides, sorry. And so this is just a little background about social determinants of health. I assume most of the people on the call know what that is and what that covers. I always like to just share a little bit about sort of the way we're thinking about it, just so we're all talking about the same elements. And so we really look at how does the conditions that people live, work, play, impact their health. And I'm from the mental health world, so I'm very partial to mental health and how that impacts a person's overall healthcare. And so this has sort of been the perfect project for me to look at how do we help people with what are things that a lot of times social workers or care managers are trying to address in sort of a bigger way in our community. And so what we're really trying to impact is that 20%, that 80% of your overall health that's not addressed by healthcare delivery and genetic makeup. And so we're really trying to look at people's physical environment, social and economic factors, and the way that they behave and the environment around them. So the goal of this project, as Dr. Kinnick pointed out, it's funded by CMS through the CMMI Innovation Group. And so what we kind of see as really the bottom line of this project is we're trying to study if addressing and identifying social needs impacts healthcare costs and reduces healthcare utilization. And what we mean by that too is really unnecessary utilization. So people that are going to the emergency room really because they're cold or they're hungry or they couldn't afford to get their blood pressure medication filled because they bought food for their family. And so really that's what we're trying to target, is people who are accessing medical services and are sometimes those high cost individuals in an organization when really maybe we're not touching what's really helping, could really help make them better. So another piece of this is that CMMI, when they put out this questionnaire, there's actually a lot of different social determinants of areas that we can screen for. MyHealth, after piloting this and realizing it took 12 to 14 minutes for someone to complete the questionnaire with a patient in a clinical encounter, and then what Dr. Kinnick talked about us having to kind of go back to the table and rethink this, we have decided to focus on, and all of the CMS groups, all of the groups doing the CMS project have to screen for the 5 major social needs. And that is housing instability and quality, food insecurity, transportation needs, utility needs, and safety or domestic violence. And what we found is There are some really interesting questions about mental health and substance abuse, but a lot of people have survey fatigue, and so we really want to try to reach and assist and help the most people possible through this project. So we ask in the CMS questionnaire, they ask 3 qualifying questions, and then they ask 9 questions about these 5 core social need areas, and then they ask a few demographic questions. So that gets us to 20 questions. And we really felt like, at least to start with, that was where we wanted to limit the questionnaire. Asking additional questions about mental health and substance abuse is sort of another project, and we, hope that we can, build this into something that we can continue to expand on. But at this time, we're sort of assisting people with these core needs and providing resources. So the goals of this project are that we screen 75,000 patients annually, and that's really a pretty big number, especially thinking about trying to sit in the emergency room and ask people questions on paper. So this is sort of where we have an advantage, or where we think that our innovative methodology has really given us a lead, a step ahead. And so our goal with our methodology is to really have the greatest impact for the patient while minimizing the burden of screening in clinics. We know in a direct care situation, there is very little time in a clinical encounter to ask 12 more questions or 20 more questions. And so we're really trying to use this tool as a way to help our clinical delivery partners provide care for their patients and to identify needs that are existing in their clinics without having them have to ask these questions and take time out of their normal clinical encounter to address these things. So again, as David said, we are using a standardized screening tool. All of us around the country, there are 30 of us doing this project. We all use the same questions. And then part of the project is, I'm going to talk through the mechanics of how it works in just a minute, but we screen people for needs, but then our goal is to provide every patient an individualized community resource summary. And so for any identified social need, we actually send back immediately to the patient when they complete the screening a resource list with resources for their identified social needs. So if they indicated they have a food need, we send them back 3 food resources that are custom to their home address. And I'll talk a little bit more about that specifically here in just a minute. And so the second part of this project that CMMI put out is they want us to screen for and provide resources to individuals who identify social needs. But then they're really trying to target high-risk patients for additional navigation services. And what they mean by navigation services, sometimes I've learned in this work that people mean different things by that. But really, they're trying to target those people who are who've been to the ER multiple times. So the qualifying question for CMS to define a high-risk patient is someone who has been to the ER 2 times or more in the preceding 12 months. And so that's how they are sort of pulling out and identifying those high-risk individuals. So to be referred for navigation services, you have to have those 2 ER visits, you have to be Medicare and Medicaid, and you have to have a social need. I will say, this is our disclaimer that we say on any of these talks. MyHealth has actually decided to screen everyone in our community. So we screen commercially insured, uninsured, underinsured, as well as Medicare and Medicaid. But MyHealth actually covers the cost to screen those commercially insured and uninsured, underinsured individuals. CMS pays for or funds the Medicare and Medicaid portion of this. But MyHealth really thought when we went to our community and proposed this methodology that clinics would certainly want to know what the needs are of their commercially and uninsured population. And I'm going to show some data here in a minute that we've collected. And we have found a pretty high rate of need in commercially insured individuals. I think we were a little surprised by that. Probably those of you who are direct service providers won't be surprised by that. But we certainly felt like we didn't want to leave out that sort of group in doing this work. And then the other part of our job for this project, as Dr. Kinder kind of explained, is that we serve as the bridge organization. So it's our job to bring together not just clinical sites and screen for their patients for these needs, but also to bring community resource agencies to the table. and to really partner with them to make sure that we're giving high quality resources to individuals we send referrals to. And we partner with resource agencies in all the communities we work in. And one thing I haven't mentioned yet is that originally MyHealth was approved for this project in Tulsa County and Oklahoma County, but we have since been approved by CMS to screen and provide navigation services across the entire state of Oklahoma. So it's a pretty big geographic area that we're trying to tackle. And we are lucky to partner with the Tulsa and Oklahoma City County Health Department to help us do this work. And they actually provide the navigation services. We work closely with them to provide a really high quality screening and referral as well as navigation. So this is kind of the process. This is the way it looks, trying to think about where does the information live and where is the burden of the screening. So I'm going to kind of walk you through this. So we start at the clinical delivery site. When a patient checks in at the clinical delivery site, we see within, Dr. Kinnick mentioned, 1 to 2 minutes, we actually get an arrival message from that clinic to our HIE. And when we get that arrival message, we batch up all the phone numbers from all the arrivals and participating clinics in that minute, and we send them a link, a text message that has a link to the screening in the message. The message is sort of intentionally, generic isn't the right word, it's not what I want to say, but it does not say, because of your visit to Dr. Jones, it says, your healthcare provider requests that you take the following screening. We are really conscious of the fact that we have access to PHI and that we are contacting patients directly. So in this process, it is our goal to not disclose PHI at any point during the process. So when we send a message to the patient, it is triggered and they're usually standing right there in the waiting room. And so usually the front desk staff will say, hey, you're going to get a text message from us. It's a screening. It can help you connect you to additional services or resources. And so we feel like it's really important for the clinics to let patients know that this is coming, but we also want to be sensitive to the fact that if someone's husband didn't know they were at the doctor, we don't want to disclose that by sending a link. So we don't identify based on your visit to X. We've tried to be really sensitive to the message that's being collected and transmitted here, especially because we ask questions about domestic violence. So from there, you can see that the text message arrives on the patient's cell phone. They open the message, they click the link, and complete the social needs screening. We find it takes most patients about 2 to 3 minutes to complete it on their own. So this is a pretty huge improvement from the 12 to 14 minutes it takes in a clinical encounter to ask these questions face to face. We also have read some studies and have been doing some work on, there's some data that shows some people are more likely to report needs, especially things like domestic violence, through an electronic means or an iPad or a cell phone, because they may or may not feel comfortable sharing that face-to-face with someone in an encounter. So when a patient completes the screening, every 30 seconds we actually draw down survey results, and we process those results here at MyHealth. Again, when they take the screening, at no place in the screening is their name or birth date or insurance or anything in that. They take the screening question by question, and each question, when you hit enter to go to the next question, nobody can go back and look at how you answered. So again, trying to think especially about domestic violence victims. If an abuser would happen to pick up their cell phone and see a questionnaire, they cannot click back in the screening to see how someone answered or did someone make a disclosure. And so we try to be really sensitive to that. So we bring the results here in, we process the results here at MyHealth, and if there is no health-related social need identified, that's sort of the end of the process. If there is a health-related social need identified, we immediately generate a custom resource summary and send that back to the we send that back to the patient via text message. And so again, they get a text message back that says you can access resources here. We send back, if they have food needs, we send them back food resources. If they have housing needs, we send back housing resources. But for domestic violence, we also thought about, we don't want to just send someone domestic violence resources. We want to make sure that if someone picked up their phone, they don't see something that would lead to them thinking a disclosure had been made. And so for domestic violence, we actually send you back some food resources, some housing resources, domestic violence resources, and transportation. So it's still truly custom. It's just a little more discreet, is probably the right word, when we send that back. So that's sort of where the process ends for the screening and referrals. But then every morning, we generate a report that goes to our partners at the health department that indicates the screening answers for the patient. We match demographics and screening answers back here at MyHealth and send that report to our patients at the health department. They then take those report results and go and enter the screening results into the CMS data system, as David alluded to. It is the process that we have and what we live with. When we enter in the CMS data system, it then tells us which patients qualify for navigation. We do a lot of checking on our end too to make sure all of that is entered correctly, and we have a lot of quality control processes in place. But then once that is entered into the CMS system by the navigator, they actually then pick up the phone and call the beneficiary and explain the project, explain why they're calling, and ask if the patient would like to participate in navigation services. And so at that point, through this project, we open a case, a navigation case with them. That patient can get assistance funded through this project for an entire year. And so that navigator will call them daily or weekly or monthly, depending on their needs and the patient's wishes. And so they actually will help them fill out a SNAP application, or they will help make them an appointment to go to the food bank. And so it's a much more sort of hands-on process once they get to navigation. So that's the process. I'm going to keep going, but if you have questions about that, feel free to enter those questions in the chat. So this slide really just shows you, we wanted to share, we have a screening demo link. It's green writing on the slide. You're welcome to log in and take it. You can kind of see how the survey works. It's actually really user-friendly. It works really quickly on a cell phone, but you can also access it via a computer. So a couple other things I just wanted to point out is that, like most people, I'm a busy mom, and I have more than one time gotten something on my phone or a text message and started to reply or started to do a screening or questionnaire and then gotten distracted and not gone back to it. So we, thinking about real life, realized that could probably happen. And so we are collecting results all along the way. So if after 30 minutes, someone hasn't touched it again, but they did indicate to us in the first 6 questions that they had a need, we actually will process those results and send them resources based on that. But that link remains open. So if they want to report another need or they go back and finish it, we will continue to process those results and assist them with any identified need that comes up over the period. I think the rest of that I have covered. So I just wanted to show you, this is actually some screenshots from a cell phone of what our screening looks like. It's actually really user-friendly. There's a privacy notice in there. The first question we ask is, would you like to complete in English or Spanish? So we make this accessible via this mobile link for English and Spanish. We have accommodations to make other languages accessible as well. There's just a different process for that. And the next question and the next slide shows, so what we have done to generate this community resource summary is that we have created a database here at MyHealth of resources now all across the state. And so as you can see from this map, obviously the heavy areas, those are our 2 big metros, Tulsa, this is Tulsa and Oklahoma City. And so there's a lot of resources in that area. But as you can see from this, every county in our state, there are available resources. And so part of this work, we had to say to CMS, yes, we can provide assistance and resources to people anywhere in our geographic area. So we have a database that has all these resources in it. And to be honest, we're adding to and expanding this all the time. So we are, I think, well over 5,000 resources in our database at this point. And And so we use this resource database to create the referrals that we send to the patients. And so I just want to kind of show you, this is also a screenshot. I really wanted to show you what it really looks like on a phone and not just tell you about it. But when we send back resources, we use that database to create the custom resources for the patient. So we send back one resource that is based on their home zip code that is what we call like a high quality, easy access resource. So it's somewhere we know we can send patients that does not have a lot of red tape and that patients can go to. They have lots of open hours. So that's the first resource we send. The second resource we send is what we call a sustainable resource. So it's a federal or a state program or a hotline. For food, we send information on how to apply for SNAP. For domestic violence, we send the National Domestic Violence Hotline number. So we try to think about sort of a more long-term or sustainable resource access. And then the third resource is actually the closest resource to their home address. And so it may be a small little food pantry in the church in the neighborhood next door. Something that probably I would never know about. And as some of our clinical partners have care managers, and they found that this is really valuable, is that it's all of the resources we provide are custom to the patient's home address. So even if they're seen in Tulsa, but they live in Claremore, they will actually get Claremore resources because we wanted to try to meet people where they're at. So that's how the resources look. So now I want to share some results. I'm plowing through. I hope that's okay. We are now almost a year into this project. We went live with just a few clinics August 1st of 2018. And this is kind of where we're at. So we have offered to screen, and by offered to screen, we mean we have sent screenings via a mobile link to over 200,000 patients in the state of Oklahoma. And so from that, we are gleaning some early data, and I'm going to couch this with saying this is early data, and this very, very well may change. We actually are just entering year 3 of the grant and our cooperative agreement. So we have 3 years left to assist patients and help patients in the state of Oklahoma, but also to collect data on what does public health look like here in our state. And so overall, we see that about 23% of all patients who answer the screening indicate some type of need. And I think that has been surprising. I think we do know that based on the history and the data that we've seen so far, that some patients do self-select out. So some people click in and start answering and say, oh, okay, this doesn't apply to me. So we know we have some self-selection bias here, but a 23% response rate out of all the responses we've gotten is pretty significant. And then we decided we really want to look at what is the rate by payer. So I'm sure none of this is surprising that Medicaid and uninsured have the highest rate of need. But we also thought it was really interesting that our commercially insured patients that we're screening, 17% of them are indicating that they have a need even with commercial insurance. Someone asked in the chat, what is the response rate out of 207? So I'll be honest, that's the challenge of this project. 207 are the screens we sent out. Our response rate right now is highly variable based on the clinic and the location. What we've found in this work is that the messaging and the emphasis placed on the screening from a clinic is the most important thing that will help people engage and participate. So some clinics, the response rate, I'll be perfectly honest, is like 8%. But some clinics, the response rate is 40%. So it's hard to give you an exact response rate, but know that what we tell clinics is that that's the piece they can dial up or down, right? They can have a provider mention the screening, or they can specifically, what we've learned is all the medical assistants and the front office staff, they know who doesn't come to appointments because they don't have transportation, or they know who doesn't fill their meds. And so they can also specifically say to those patients, hey, this is a really valuable program. We would love for you to participate. So I hope that answered your question. If not, let me know. So So out of those screenings, 5,000 people we have sent resources to, and those I believe are unique individuals. So we do find that people take the survey over and over. It's kind of interesting. We screen people when they enter a clinical delivery site once every 30 days. So if you go to an OB appointment every week, we are aware of sort of survey fatigue and we want to combat that. So we don't send a screening every time they walk in the door. We feel like at some point people are just going to start ignoring us. And so we actually, based on the clinical delivery site and their preferences, we've put into place a 30-day sort of window. And so what we, sort of the theory behind that is that if the day I go to the doctor and I'm employed and I'm doing fine, but tomorrow I lose my job, 30 days from now, I very well may have a food need, or I very well may not be able to pay my utility bill. And so that's sort of the logic behind our frequency of screening. And patients certainly always have the option to opt in or opt out, as well as to participate or not. And so there's, each clinical delivery site, the beauty of this too is they sort of can impact how much or how many of their patients are screened by how much emphasis they put on this or who do they target in their clinic. We're currently screening in clinics and emergency rooms, and it's been really interesting. Probably not surprising, but emergency rooms have a much higher rate of need, but we have a harder time contacting people from emergency rooms because of bad phone numbers or incomplete information. So it's certainly been a learning process in this, and we have a lot more to learn. We've spent the first year really sort of refining the process, getting it off the ground, engaging participants, and are really looking forward to doing some more impactful quality improvement over the next several years. And so this is sort of the results of our screening so far. In every payer class, food need is the highest need. And when we think about this, I really think one thing we always sort of try to keep in mind is really what we feel like we're identifying here are resource needs. So someone doesn't have enough money to buy their medication, to buy food, to pay their utility bill, and to have a car. And so what we think, I'll be honest, this is sort of personal theory. Food is often the most salient need for a family. So if you don't have something to feed your children tonight, the first thing when I ask you what is your need is you're gonna say food. The reality is you don't have enough resources probably to meet all the bills that you have. So food need is the highest, and then we have seen that utility needs is actually is the second highest in some of our populations, and living needs is the second highest in some of our populations. And so it's interesting because this is where we sort of start to see some differences in payer class. Safety is a very low percentage. I think it's about 3 to 4% of our population. And this is honestly about the same percentage range that our partners who are doing this project across the country, but not in a mobile screening method, are seeing as well. And so there's still a fairly low rate of reporting there. But we do feel like we are detecting safety needs that sometimes clinics aren't aware of. And the thing I will say about this, I don't have a slide or anything, but we frame this entire project as your healthcare provider would like you to participate, or your healthcare provider cares about your social needs. And so on the back end of this, we actually send back to the provider every week the list of their patients that are screened and who had identified needs. We really feel like it's really valuable for the provider to know who are we working with, who are we assisting. Some of them use the report we send back to them as a way to sort of triage and say, okay, MyHealth through the AHC project is helping these 200 patients. We have these 15 commercially insured patients who indicated they have some physical violence in their home. We want to really prioritize as an organization that we're going to reach out to those people over the next week. And so it's really an organization's it's their patients and it's their data. And so we want them to be able to use the data and intervene with their patients in the way that they find most helpful in their practice. Okay, so I think, I spoke really quickly, so that is the end of sort of my prepared slides, but I would love to answer questions. And Lisa, I don't know if you want to help to facilitate some of this, or Dr. Koenig, if you had anything you wanted to add. Someone asked, actually really quick, someone asked, in the communication to the provider, do you indicate when the need was met in order to close the loop? So that's a really great question. And we send back to the provider who is working with the navigator. Sort of the next step of this project, we do close the loop ourselves with the navigators. They actually confirm and make sure that the patients got their needs met. And so that's a really important piece of this work. And actually part of what we report to CMS is were the needs resolved, and were they resolved successfully or not successfully, or did the patient, you know, at some point drop out? And so we definitely always are trying to close the loop. However, we've been discussing with providers what is the best way to get that data back to them. And as Dr. Koenig mentioned, when we started this work, we really thought we could say, okay, we're going to take some social needs vital signs. Do you have a housing need? Do you have a food need? And then, you know, work on sending back a very brief, basic code that says, yes, this person had a need, and yes, their need was met. We found that it's not that easy. The social determinant of health world doesn't have standardized codes, and there's some work being done nationally to work on that. So we are trying to figure out the best way to indicate back to the provider. We have had providers say, we'd like to know what resources you give people and if their need was met. And so we are planning to start adding that back into our provider report, but we're also looking at how can we help providers get that data back into their EMR. Okay, someone else asked, what is the uninsured rate in Oklahoma? I actually do not know that off the top of my head. I would have to look that up. I'm not sure if Dr. Kendrick would know that. That is something I'd have to get back to you guys on. I can certainly find that information.
It's 16 to 8, I'm sorry, Jennifer, it's about 16 to 18%, and we're not a Medicaid expansion state, so we've got a pretty high rate of uninsured.
Great, thank you.
So Jennifer, this is Lisa. I just wanted to point out, you alluded to this earlier, the concept of people being underinsured. And so that section of the population that when you did your screening, people with commercial insurance, but who were really demonstrating significant social needs, socioeconomic need. So I think that's another piece of the puzzle in terms of, you know, people really having insurance, but not nearly adequate to what they actually need in the big picture.
Yeah, and you know, our health systems are really finding that this information, I mean, honestly, the bottom line is, right, we want to help people and we want to help patients and we want to help meet their social needs, but health systems are finding that this data is really valuable. A lot of them didn't have numbers to put with, you know, how many people who are uninsured are we helping, and being able to say their need is 20% greater than our, you know, Medicare population. Or I think that this data is really helping to put some numbers to what direct care providers see and what they know, but we haven't been able to sort of formalize or communicate about in terms of percentage of patients impacted. So. Someone else asked, what need category would affording medications fall into? And Eric, that's kind of what I was alluding to here is I think, you know, we have decided to just screen for these 5 core needs. There are certainly many more social needs that we could access or ask people about to see what their access is to assistance. We have found, to be honest, this project has spurred lots of other ideas and opportunities that Dr. Koenig and I would really love to sort of explore and ways that we could deploy this technology to get to answers like that. We really try to think about the needs that are identified here as a way that patients can indicate that I have a lack of resources. And so I think your affording medications falls into, did they decide to feed their family today or did they decide to buy their blood pressure medication? So I don't have a perfect answer to that, but certainly that's what we're trying to say here is that by screening people, we find there are 23% of all the people we screen have a resource deficit that is in some way impacting their health.
Are there other questions? Oh, yeah, go ahead, please.
So I was going to add to that point that, one of the nice things about having built this screening at the middle layer, so to speak, rather than depending on each clinic's EHR to trigger this screening event or each organization's EHR, but instead by triggering it at the community level, we have also lots of other data about the patients to get more tailored about our screenings. The 5 we screen now are really mandated by CMS for the program, and that's what we do. But we have the possibility to do much smarter screenings based on what else we know about the patient in the future, and I look forward to doing more of that once this project is wrapped up, hopefully successfully.
Thank you, David. This is Lisa. Have you seen much interest on the part of the 30 other places that are involved in this CMS program? Is this something that seems applicable to other parts of the country where they might have a information network that could be applied?
Yeah, to be honest, I get questions almost weekly from other HC groups saying, hey, we want to text patients. How did you do that? And, one thing I'll say is that this is a really deployable, scalable methodology, but in all fairness, it has taken us a long time to get here. It's a lot more work on the back end than I think. It's not just as easy as texting someone, right? We do a lot of identity resolution. We do a lot of matching in our database of identity to screening results. And so it's a complicated process, but one that we're certainly hoping to learn a lot more about over this project and be able to help other organizations and share this and deploy sort of the technology aspect of this. But yes, there is lots and lots of interest. And as David sort of alluded to, we really want this, we would need to get this project to be successful and to meet the milestones we have for CMS. And we have big numbers that we have to meet. And we, by us going back to the drawing board and sort of coming back to this mobile screening method, we've had to go back to leadership at organizations and say, hey, we have a new idea and get the consent to do that. And so I'm not going to say it hasn't been a lot of work because it has been a lot of work, but yes, there is a lot of interest around the country and even at CMS about how could this sort of technology and, as David pointed out, the community-based integration of the screening be applied in other arenas. Any other questions?
Great. Well, Jennifer and David, thank you so much for sharing this incredibly exciting information. For everyone on the phone, this webinar has been recorded, and we will also be posting the slides which you already had received in PDF format on our website. So you'll be able to contact Jennifer and her colleagues if you want more information. I think this is really one of the great opportunities to enhance the services of people who we are taking care of in the clinical setting, and recognizing that it truly takes the expertise and diverse skills of a team of people. And this type of screening really does the kind of outreach that often is very, very tricky to do. So Jennifer, thank you for your great work and your really wonderful presentation today. And thanks to everybody for dialing in here in the midsummer. Really appreciate your participation. Have a good rest of the day. Bye-bye.
Thank you so much.